Good afternoon, respected delegates. It is my real honor to be present in this unique conference. And I am really thankful to Professor Shoilendra Handu sir, Professor Shoyad Jiaur Rahman sir, and Professor Puneet Dhamija sir and his team for giving me this opportunity. So for next 20 minutes, we'll discuss about this unique concept of clinical pharmacological reconciliation, review, and feedback, and how we can use this principle to ensure patient safety. So we know this gentleman very well. We know our army men, we know our CRPF, who are always very much attentive to prevent any type of atrocities inside our country. That atrocities can be from outside country or from within country. They are always there with the vigilant eyes. So similarly, to prevent medication related atrocities, we are using this terminology CPRRF, Clinical Pharmacological Reconciliation, Review, and Feedback. This is what we are going to discuss today. So first of all, we'll discuss about why it is important, why it is required, what is this CPRRF, and how it could be utilized. Yes, there are some propaganda newses always in India, outside India, to malign our profession. You can see this headline, which is very much unfortunate. We know yesterday also we lost our sister in this crime against doctors. But the sad truth is also we need to acknowledge that the third leading cause of death in US, which almost killed more than 2.5 lakh people, and some agencies are claiming almost 4.4 lakh pupils due to these medical errors. And that is why they're mentioning it like that. Medical errors are the third leading cause of death after heart disease and cancer. And we can see this picture of this beautiful girl. We also lost this girl because some pharmacy technician filled her intravenous bag with more than 20 times recommended dose of sodium chloride. We don't know what is the actual picture there, but this was quoted from the very leading newspaper in US. And in India, also, we are unfortunate to have almost 43 million injuries each year due to this medical care. And 23 million daily are lost due to the consequences of these medical errors. 5.2 million medical errors occur annually in India. Very recently, the Times of India had quoted one of our publication. They represent it little bit in a different way, but we can see the headline: half of Kolkata's elderly on multiple pills, victims of drug duplication. Similarly, the another news which had stressed upon about the doctor's stress on need of synchronizing medications, reconciling the medication. And they had quoted our study reports there. The thing is that we had done one urban camp of clinical pharmacology camps to assess the polypharmacy and also what is its impact on cardiovascular autonomic function, especially among the geriatric population. And we found that the anticholinergic burden and the proportion of the patients with cardiac autonomic neuropathy were significantly higher among patients who were on polypharmacy than who were not. And also, our conclusion was like that the polypharmacy was significantly associated with CAN among community dwelling elderly patients. So we had this community-based clinical pharmacology camp, and we found this interesting finding. And from very beginning, if we go back to 1970, WHO had proposed the clinical pharmacology as a discipline who had a lot of scope in patient care. We can see here the first line which was proposed as a function of clinical pharmacologists was to improve patient care by promoting the safer and more effective use of drugs. So when we are talking about improving patient care by this discipline, the first thing what we can propose, the CPRRF, Clinical Pharmacological Review, Reconciliation and Feedback of Drug Therapy through our OPD services and also inpatient management. Specifically, if we need to have some specialization in drug-induced diseases or drug-related problems, that could include the drug allergy too. So that is what we want to stress in this presentation. So what is actually this CPRRF of drug therapy? There are certain important areas which we can cover through this CPRRF of drug therapy. Number one, while we are assessing prescription, we need to check whether there is no indication for a current drug which is consumed by our patient. There could be indication for a drug, but not prescribed. Necessary but wrong choice of a drug or regimen, or unnecessary and redundant drugs. So we need to apply here the principles of de-prescribing. Too much or too little a dose, adverse drug reactions including drug allergy, drug interactions, incompatibility. There could be overlapping of adverse drug reactions, adherences issues. Also, at the same time, we need to stress upon the affordability and availability of the drug. When a patient is taking some drug for long duration, we need to monitor the drug therapy. Both the safety and efficacy, we need to check. Prompt review of freshly prescribed drug regimens, which we don't have any previous knowledge. If that medicine came into the market, we need to be more cautious. And here is the need of application of CPRRF. For an example, now we all know Finrenon is something which is going to be a rocking in this market of diabetic kidney disease. At the same time, we are getting a few cases of hyperkalemia. So it is our duty to monitor those patients who are initiated with Finrenon, whether they are developing hyperkalemia or a sudden deterioration of kidney function. We need to look after this patient with vigilant eyes. Consider specific patient factors, and this is the era of individualization or precision therapy. So we need to use our pharmacokinetic, pharmacodynamic rationale with each prescribed drugs. And of course, polypharmacy is a critical issue. And when we are dealing with our geriatric population, this is a major issue. Generally, for an ambulatory patient, for a given diagnosis, not more than 3 medicines are usually needed. Yes, there are some exceptions, like in case of tuberculosis, like in case of HIV, we need multiple drugs, but usually it is not more than 3 medicines. If it is more than 3 medicines, we need to be cautious. Adverse impact on quality of life. And that is why someone proposed we need to be more towards patient-oriented evidences, because patient-oriented evidences that matters more than disease-oriented evidences. So poems are more important than DO is. So another important issue is during the transition of care, medication errors are very common. We need to be very careful there. So in general, the principles of CPRRF, the mool mantra is medication without harm. Yes, there is no medication available without any adverse effect, but it is our duty to minimize the harm, or at least try to prevent the harm. We need to diagnose drug-induced disease. And unfortunately, this is a neglected differentials. So when we are seeing our patient, it is important to consider this entity called as drug-induced disease. Treating adverse drug reactions and preventing their recurrences. That is again an important, and for that, we need to understand that this is an adverse drug reaction. Otherwise, how we can prevent their recurrence? Avoid prescribing cascade. We'll discuss little about this concept of prescribing cascade. But the main mantra, specifically in geriatric chronic care, start low, go slow, but we have to go. But yes, there are exceptions, like in case of a critically ill patient, when we are seeing in ICCU, the patient is suffering from chronic kidney disease and patient is having sepsis. That time, if we follow this mantra, then we'll lose our patient. And sometimes what happens, if we not use our pharmacokinetic, pharmacodynamic rationale there, we use sub-optimized dose of antibiotic, where we all know the loading dose concept of antibiotic is much more important than those EGFR-based reduced continued dose of antibiotic. So that is a separate area, but what is important, what we want to impress upon, that we need to use our pharmacokinetic, pharmacodynamic rationale where it is necessary, and every patient is different. We need to use de-prescribing principles. That means stop any drug that with having no benefit or without known benefit, or actually having some adverse effect potential. Substitution with class eliminates adverse drug interactions and adverse drug reactions. Special prescribing considerations in case of renal or hepatic compromised case, pregnancy, pediatric or elderly population. Let's discuss one case, a 68-year-old lady suffering from both knee osteoarthritis, severe weakness for 5 days, pedal swelling for last 5 months. So suffering also from hypertension, diabetes, ischemic heart disease. We can see obesity is there. So current medication list we'll find here. But what happened? Maybe 6 months back, he was prescribed with a fixed dose combination which contained diclofenac. But for relieving her pain, she's also taking this combination nowadays twice a day. And to reduce the pedal swelling, she was prescribed with furosemide 40 milligram for 7 days. Now, what happened after this? The HbA1c, we found it is quite high, There is hyponatremia, hypokalemia. We understand why it is happened. This furosemide use. The kidney function is compromised. And now if you can compare the ongoing medication list and the kidney function, then also you will find there is gross mismatch with the EGFR and this ongoing medication list. And we now understand, as the patient is having obesity, she is suffering from more pain, osteoarthritis was there, and also she was taking some drugs like pioglitazone, pregabalin, amlodipine, which cause pedal swelling. And to reduce pedal swelling, without targeting the cause, the patient was given with furosemide 40 milligram, which causes hyponatremia, hypokalemia, leading to severe weakness. So this is the thing what we need to make out. And also we found here, as the patient was not informed about the potential hazards of diclofenac containing fixed dose combination, she was consuming it. She is having diabetes, long duration, uncontrolled diabetes, along with this potentially kidney toxic agent, so which hampered her kidney function more, deteriorated the EGFR value, and we found what happened. And also, we know this is a very small drug-drug interaction, but we need to acknowledge, if we use calcium carbonate salt with PPI, the PPI will reduce the calcium absorption. So what is the need of taking calcium salt? So this is an ideal case who requires this clinical pharmacological reconciliation service. So what we do, we need to target the main disease pathology, and that is obesity. So patient is taking some drug, glimepiride, pioglitazone, which also known to increase body weight. So what we did, we de-prescribe all those agents which is associated with weight gain. We use dulaglutide, which is a GLP-1 receptor agonist, which reduce body weight quite. Along with, we reduce the metformin dose according to the EGFR value. And initially, she was on basal insulin as there was some derangements on the sodium potassium level. But after that, we had initiated dapagliflozin. For pain, we only give paracetamol. The calcium salt was changed from carbonate to citrate. And also, rosuvastatin was changed and other things done. The more stress was given on lifestyle modification and physiotherapy for controlling her osteoarthritic pain. And we can see the result after 6 months. Quite improvement in EGFR. There was no pain decreased a lot. No pedal swelling, and HbA1c, the glycemic control was achieved. So what is important, this is happening in this type of patient. The patient is suffering from some adverse effect, but without treating that adverse effect, I am giving some medicine to control those ill effect. But what medicine we had added, that also causing some other adverse effect. And to control again the second adverse effect, I am using a third agent. So to control the third agent induced adverse effect, I am again using some fourth agent. Ultimately, what happened? The fourth agent will cause the same symptoms for which we started the first agent. So this is a cascade, and this is called prescribing cascade. And one of the major goal of clinical pharmacological reconciliation review and feedback is to prevent this prescribing cascade. We had published this in JAPI, and we are fortunate to have the Jivraj Mehta Award for this case series. Let's have some concerning number here. Polypharmacy, yes, polypharmacy, there could be a legitimate need of polypharmacy, But if we go by the number, both sides of Atlantic, they have more than 40% prevalence of polypharmacy. And when we are talking about elderly population in US, there is 40% prevalence, and which increased from 99 to 2012 by 15%. And ambulatory elderly patients who were 84% on more than 5 medicines and 43% on hyperpolypharmacy. That means 10 or more drugs. And Indian situation is not also good. There is a pooled prevalence of polypharmacy of almost 50%, and hyperpolypharmacy is 31%. But the concerning number is 28%, that is the potentially inappropriate medication use. And we need to target to minimize this potentially inappropriate medication use. We all know the definition of polypharmacy. That is a qualitative definition and quantitative definition. If we quantitatively define polypharmacy, it is more than equal to 5 drugs per prescription. It also need to acknowledge it should include over-the-counter drug, prescription or non-prescription drugs, even the traditional and complementary medications. But what is important is that we need to assess polypharmacy quantitatively. And for that, we need to use the terminology potentially inappropriate medications. What is that? The medications with ineffectiveness or high risk versus benefit ratio for a particular individuals or group of individuals. And there is the appropriateness of therapy is more important than the numerical counts only. And whether we need to check the potential benefits outweigh the potential harms. And when we are talking about polypharmacy, again, it is important to acknowledge that inappropriate medication use and underuse were common in our older population who are taking 5 or more medications. So both inappropriate medication use and underuse, both are important for our, if the patient is taking more than equal to 5 drugs. And it is important that we, prescriber and patient, are connected by this prescription. And prescription is a very risky behavior. It is our duty to have some balance between these risk and benefits. There we can find the relationship between polypharmacy and underprescribing. And here we reported this case, rheumatoid arthritis patient who was taking long-term corticosteroids, suffered a tibial injury, which requires ORIF, open reduction and internal fixation, just for a low velocity trauma. What happened? The patient requires anti-osteoporotic treatment, but she was denied and she was taking lots of medications. So how polypharmacy is directly linked with underprescribing, we can have an experience from this case. So that is why we need to know the arts of de-prescribing. But it is important to acknowledge that de-prescribing is not about denying effective treatment to eligible patients. This is the systematic process of identifying and discontinuing drugs in instances in which existing or potential harms outweigh existing or potential benefits within the context of an individual patient's care goal, current level of functioning, life expectancy, values and preferences. Lots of factors that govern us, the process of de-prescribing. This is nothing but a positive patient-centered intervention with inherent uncertainties are there, requires shared decision-making, informed patient consent, and close monitoring effects. So de-prescribing considers not only the risk associated with individual drug, but also a cumulative risk from multiple drugs due to PK/PD interactions. So we need to diagnose a problem and we need to check whether there is something use of an inappropriate drug is there or not. Then we need to make a therapeutic decision, that is withdrawing it, or after withdrawing, what is important, we need to have a close follow-up. And then we need to find out that whether this withdrawing altered the natural history. That means reduce the incidence of drug-related adverse events like falls. If I am withdrawing prazosin, we need to check for long duration what is happening to the patient's blood pressure. And also we need to check whether after withdrawing the prazosin, which was causing postural hypotension, so after withdrawing it, whether the fall events are reduced in this patient. So it is always important to acknowledge prescribing is not a snapshot. Good prescribing is a continuous process, which includes therapy initiation, dose titration, changing or adding some drugs, also switching or ceasing drug therapies. And when we are talking about polypharmacy, specifically in elderly population, we need to evaluate risk of polypharmacy. There are certain tools we can see in this slide, starting from Beer's criteria to stop criteria to start criteria, and also medication appropriate index. So there are lots of studies conducted which had suggest that elderly population is highly vulnerable. And for that elderly care, there is medication related problems that are inseparable from their broader life. So we should have a social and emotional context of medications and related communication. What are the medications obtaining? That is, there could be a problems with cost, insurance coverage, taking medications, whether there were someone who make them remember to take the pills, medication effects, including side effects, concern over lack of effectiveness, communication and care coordination, including information-related medications that we already had observed in the discussed case where the patient is consuming diclofenac without knowing the harm of the agent. So this is again a study conducted by us which had suggest the anticholinergic burden in our geriatric patient is really concerning issues. Almost 23% of population were on a significant level of anticholinergic burden. We know that if the score in a prescription is more than three or more, then that is something significant issues and we need to de-prescribe accordingly. These are some drugs which is not classically anticholinergic, but they have inherent property of anticholinergism. We can see if a patient is taking amitriptyline, along with that, if we use some other drugs, very common drugs like atenolol, which also has a ACV score of 1, but the patient is taking amitriptyline. So 3 + 1 = 4. So for that same patients, we will have a score more 3 or more. So they have more chance to develop different anticholinergic side effects. There is again a case where a young boy was taking antihistamines known as clemastine for a long time, and for migraine he was taking the amitriptyline. And what happened? He was suffering from erectile dysfunction. Lots of medications was used, but it was not improved. What we did the de-prescribing of clemastine, which has a high anticholinergic burden along with amitriptyline. Both have 3 score of anticholinergic burden. Ultimately, 3 + 3 = 6. So we de-prescribe that, and we also give alternative to that, and the erectile dysfunction improved. So simple de-prescribing can improve from some drug-induced disorders. And there is another important entity, as we are already mentioning again and again, drug-induced disorder. Sometimes the physicians may think that this is due to some drugs, but it is our duty. The principles of CPRRF can tell us that this issue is not related to drug. And that was again a case where primarily the treating physician was thinking the patient on allergen immunotherapy developing systemic lupus erythematosus due to allergen immunotherapy. But detailed investigation by our team found out that there is no link between this SLE and allergen immunotherapy. Again, another important case where ranibizumab-induced infarction happened, and we tell our patient not to take the second time this ranibizumab, which prevent atrocities in that elderly lady. So it is important for us using this principle of CPRRF, diagnose drug-induced disorders. What is most important is detailed medication history. History, and history. After that, yes, there are some role of clinical examinations, laboratory investigations, specifically in the background of drug allergy. We can do some tests like SPT or lymphocyte transformation test, or sometimes, very rarely, we do trip test. And sometimes we can also predict drug-induced disorders by HLA phenotyping. We always recommend HLA phenotyping before we are prescribing carbamazepine. Similarly, allopurinol has some link with specific HLA phenotyping and their allopurinol-induced Stevens-Johnson syndrome. So this is, I am sorry, this is written in Bengali, but what is written in here? Oshudher rog sarate outdoor tropical. That means there is OPD was initiated in School of Tropical Medicine to treat drug-induced disorder. This was done under the guidance of Professor Santanu Tripathi. The clinical pharmacology OPD was done. So again, this was a recent paper of us where we suggest some clinical pharmacological interventions could be utilized in routine care to ensure the better patient outcome. So their consultations, that means the clinical pharmacology consultations, should be encouraged to improve treatment outcome, because we can promote the safer and effective medications. So this is, in nutshell, what is clinical pharmacological reconciliation, review, and feedback. Already we had discussed it in details, starting from de-prescribing to tailoring the dose adjustment to individualization of therapy and rationalizing polypharmacy, like etc. So there are some challenges. Number of specialists providing this service is very less. So we need to increase this service. Our pharmacology friends, clinical pharmacology friends should come up to give this, to provide this service. Yes, we have a lack of clinical exposures during postgraduate training, but that can be corrected. And very recently, we have some curricular changes, which also can promote more clinical exposures to our postgraduate MD people, MD students. And awareness level and confidence of the other clinical colleagues are again important. And for that, when we are doing the CPRRF, when we are doing the de-prescribing, we need to focus on, we should not shame, should not name, should not blame anyone. So no name, no shame, no blame. So that should be our mantra while doing the de-prescribing and this CPRRF to our patients. And also the administrator's willingness is important. But in general, if we can see, if we do this CPRRF, ultimately our patient will be benefited. And our administrator's goal should be how to improve patient outcome. And that is why we can address this challenge too. So finally, the clinical pharmacologist should play a significant role in promoting prudent use of medicines. WHO has emphasized the need to integrate clinical pharmacology with the health service system. It seems we still have a long way to go to make this reality. Application of CPRRF principles in different subspecialty domain is a need of the hour. Policymakers should design and execute novel strategies to speed up this process. So I miss to be physically present in Rishikesh this time. but we had a chance to visit this Punya Bhumi, specifically both with my father and my mentor, my guru, Professor Santanu Tripathi, my father, with also my father. Here we can see my father, Devdas Samajdar and Santanu Tripathi. Both, I am really privileged to be present there in an international conference on yoga. And from yoga, what we learned there, yoga means how to convert I to we. And that I to we can convert illness to wellness. So here also we need to become we from I. We means from pharmacologist field. We should have a team from clinical pharmacology team. We should make up a team-based approach. Here we means we need to incorporate our clinical colleagues, other clinical colleagues too in this broad team. We need to include our administrator. And finally, we need to take the most important stakeholders in this whole concept, that is the patient in this broad team. So hopefully we will make a broad team and we can convert the illness to wellness. Thank you very much. Thank you once again for giving me this opportunity.